It's crazy, but it's
You're watching Channel Z, the world's leading zombie apocalypse channel. Broadcasting live from Studio Z.
Makes me act the way I do.
And hello and welcome to a special spring 2023 edition of the Dr. Z Show. As always, I'm your host, Joe Alcock, MD, aka Dr. Z. By day and sometimes night, I am an emergency physician at the University of New Mexico. And when I'm not doing that, I'm interested in all things zombie, all things apocalyptic. And we have another apocalyptic conversation today, which should be tons of fun. We're going to lead you through the evolutionary medicine of the apocalypse with a special focus today on long COVID and going post-viral. The whole idea that there's a huge number, millions of people that are affected by a post-viral syndrome that we're kind of coming to grips with and debating and trying to figure out what it's all about. So we do have our longtime co-host, Athena Actipus. She may or may not come on. And oh, wait, there she is. Fantastic.
Hey.
Hi, Athena. Hi.
Long COVID co-host.
That's
I've been
right.
dealing with it for more than a year. I'm like mostly better, but you know.
Exactly. So I think, most of us now, I think there's only maybe 15% of people that are novids. People have never had COVID. So most people that are on this stream, most people in the world now have actually had COVID. So that's certainly true for North America. And many of those folks can actually get some persistent symptoms. You did. I did. Mine not quite as severe, I don't think, as yours. This really seems to be quite a thing. But we have another person who's going to be joining us. That's our return guest. She's a frequent guest. She may as well be a co-host of this program. I'm talking about, of course, Dr. Jessica Brinkworth. She's a biological anthropologist, amazing scientist, let's see, where am I going with this? You're
immunobiologist.
Immunobiologist, yes. I was gonna say immunologist, but that sounds a little too medical.
I'm an evolutionary immunologist.
Okay.
We can call me that.
Well, good.
Yeah, and I'm a novid. I've never had COVID.
Check you out.
Not to my knowledge. Yeah,
I am highly impressed. Now, every once in a while, as a pure anecdote, I did come across a patient who was describing many of the symptoms that are consistent with kind of long COVID, and we'll get into that and what that's all about. And then this patient told me that she had never had COVID, and maybe she did, maybe she didn't, but she certainly met the diagnostic criteria for the thing that we're going to talk about. But that does put you in sort of rarefied air. You've never actually had the clinical symptoms of COVID and had a positive test. So.
Never had a positive test. Never had the symptoms. No. I mean, we have a weak chain in my house. There is one person in the house who's an unreliable narrator about whether or not they're actually like masking all of the time.
Yeah.
But as she ages, I think it'll get a little bit better.
Yeah.
So I've had 4 or 5. I've had 3 to 4 colds and a flu in the last 6 months, but that's it for the last 2.5 years.
Yeah,
we tested every time and it came up negative except for influenza the one time.
Okay. Well, we're gonna plunge into all of this. We're gonna do a deep dive into COVID, long COVID, other viral illnesses that can produce similar kinds of symptoms. But before we do that, I want to remind everybody, please give us a like or love on the socials. Smash that like button on whatever streaming service you're using to watch this. And don't forget to send us your long COVID questions. And then the folks back in back of house here are gonna present those to us, and we'll see if we can answer those kinds of questions. So please do that.
Send us your questions. We want all your questions.
Let's see your questions. Let's start. So, Dr. Brinkworth, tell us, what is long COVID?
Long COVID is a post-viral syndrome. So these are they start off as a mild and usually upper respiratory tract infection, and they happen in, say, young, healthy people. And then after that, the recovery is just really, really, really extenuated. Like it goes on and on. Extended. And it's the number one symptom that's associated with this is tiredness or fatigue that interferes with daily life, and symptoms that get worse after any kind of exertion, including mental exertion. It's really big. There's something like 200 symptoms have been recorded just for post-viral syndrome stemming from COVID infection.
Right.
So yeah, and it can be lots of stuff that's like persistent headaches. You would know more about this than I would, but positional orthostatic tachycardia syndrome, like which you stand up where you move into a different position
POTS.
and you're right, POTS, yeah, and then your heart has, at least the ventricles have dysregulated beating, sweating, muscle pain, cognitive dysfunction, and just general difficulty concentrating. But it can manifest in a bunch of different ways.
Yeah. So I was looking at journal articles, and maybe I shouldn't be surprised that there isn't any firm diagnosis or diagnostic criteria for this. And it looks like in some of the definitions, like from the World Health Organization, seem to be pretty vague.
Well, okay, so we're in opening discovery around SARS-CoV-2 post-viral syndromes anyway, right?
Right.
Insofar that SARS-CoV-2 uses particular cellular pathways to achieve what it wants to achieve. And through that, it has evolved to achieve. And through that, will disrupt cellular milieu and cause symptoms as a result, right? But it's also, like most post-viral syndromes, it's multi-pronged. So it affects most organ systems. And outside of that primary core set of symptoms, which is like great fatigue, fatigue after exertion, muscular fatigue,
sleep disturbance,
it can be very, very different for each person. So that's the core thing that holds it all together, right? You had COVID, and then these symptoms going on for 3 months or longer.
So where did all this sort of come from? How did people start realizing that long COVID was even a thing?
Yeah, did it come from us doctors? I'll just put on my medical establishment hat on right now.
Right. So long COVID specifically, no. Mm-hmm. So we've known about post-viral syndromes for like over a century. But in terms of the effects of COVID, no, that came from patients, and it was grassroots organizing for patients that were in the first very, very opening first wave in Europe and in North America. So the first group that got together and started talking about it did so in like April 2020, and they connected via social media, and lots of these groups got together. And so there are these patient cohorts that are self-organized of like 60,000+ people, 100,000+ people that got together to deal with this.
I will mention that I found out about POTS from a patient. So this explains, kind of illuminates why it's important for doctors to listen to their patients, because I didn't know what it was until I actually heard about it from a patient. So wow. I was educated in that way.
Yeah. I mean, and it is important. I mean, so the very first paper that's published on this is patient organized. There were doctors involved, right? Mm-hmm. But it's that cooperation, and it was the coalition of these people, which
we have some great questions from the audience here too. So Nicole's asking, are doctors recognizing these as legitimate symptoms? Maybe that's
great. It's a great question. Yeah. So I was going to kind of pose the same thing. Like, I'm sure some of my colleagues are skeptical and say maybe this is actually doesn't exist. What if it is truly all in my patient's head?
Yeah. So I was sitting in about a year ago in a public forum that was being run by the doctors in Toronto that had been tapped by the Ontario government to have these like big conversations about next steps and stuff like that. And the head pediatric guy didn't believe in it.
Whoa, really?
Like just openly said that he thought it was due to like something else entirely and probably not real. So
related question here about, how you yourself can determine if you have a post-viral infection as opposed to just, everyday discomfort.
Well, I can give you a little bit of history, and then that can help explain both things. So we've known about post-viral syndromes for decades and decades, and they've gone by a lot of different names. So if you were to look any of these up, you would find like the very, very similar symptoms. So apart from long COVID, you could look up Acuria disease, Iceland disease, royal free disease, myalgic encephalomyelitis, epidemic neuromyasthenia, chronic fatigue syndrome. They're all roughly the same thing, or united by the same set of symptoms. And they almost always follow an upper respiratory tract infection that's symptomatic, and the patient just doesn't make a full recovery. The reason why it gets dismissed is it's kind of complex, but it's also super straightforward. Women are 10 times more often affected by these syndromes than men. And the burden's also uneven across the United States. For example, across the US population, it's usually minorities are more commonly affected. And that's because the burden appears to be associated with lots of social determinants for infectious disease or chronic disease anyway. So it tends to be more common in lower income, among lower income people and people who are in poor housing. So, but like I said, even recently, and even now it's dismissed often as hysteria. And this was really nailed into place by an examination of this epidemic that happened in the Royal Free Hospital in London in the early 1950s. So there's this retrospective that was done, and basically a whole bunch of patients in this hospital got an upper respiratory infection, and then largely women complained after the fact about not recovering. And this big retrospective study in 1955 specifically points to the frequency of women patients as reasons to think that this was hysteria and not physiological. And they backed it up by saying a bunch of stuff like, well, when people experience mass hysteria, they tend to lose hand and foot sensation, which, some people get neuropathy in long COVID, so they get pain or they get tingling and they lose sensations in their hands and feet. And we see that here, and all the labs are normal. Their 1950 some labs were normal. So there can't possibly be anything wrong. And these symptoms aren't always present. And disease doesn't work like that, except that chronic diseases and chronic fatigue syndrome, specifically MS for that matter, often takes the form of relapsing remitting, meaning that you sometimes have symptoms and then you go back. So the way that post-viral syndromes typically work is that you either take a long time and you fully recover, you go through relapsing remitting for the rest of your life, or it's chronic and you progress. And so that's part of it. In 1978, there was an international symposium that on myalgic encephalomyelitis specifically, and it concluded that this was the outcome of viral infection. So they looked at this huge inventory of data, and they said, look, every single person in here had an upper respiratory infection in advance. So it's probably that. And they immediately met with resistance for all the reasons I just said, but also because it opened up the possibility of a bunch of different agents being responsible, because in some cases, people had Epstein-Barr virus, or, it had mono. In some cases, they had influenza. In other cases, they had Coxsackie viruses. So this meant there's probably lots of different pathways by which it was happening, and therefore lots of different pathways engaged after the fact.
And quite frankly, doctors are not that smart.
Well, it's just not the way
we can only deal with one pathway at a time.
It's just not the way that people thought about diseases then. And frankly, a lot of people even now don't think about it that way, right? They think about singular pathways and singular causes. And so the idea that there could be lots of causes was a problem.
That's what we're taught.
Is that how you're taught?
Yeah. I think that this degree of nuance and complexity and what we were talking about before the show, that these are microbes that are manipulative and subvert the immune system and are interacting with an evolved system, which is our bodies. That's a very hard thing for doctors to wrap their heads around, speaking as a physician myself.
Can I ask you a question? Mm-hmm. This is a diagnosis of exclusion, right? It cannot, we have these labs, we've done this clinical examination. For most of its history, post-viral syndromes have been diagnosed as there can't be anything else. You had this, and there can't be anything else now because we've tested everything else. So in your view, like as a physician, how certain are you when you say, well, it doesn't look like a horse?
Yeah. No, I worried about that because I had a patient not that long ago for whom I discussed the possibility that they potentially had one of these syndromes. And I was worried how it was going to be taken because it did imply that the tests were negative. And I was saying, hey, this is a thing. And I gave them all kinds of literature on it. But I still felt this was a little bit outside the kind of boundaries of what emergency docs do. And if that person was there to get diagnosed with, a more traditional emergency, they might be put off with the idea that I'm telling them they have long COVID, right? So it's a tricky thing. And I don't think that we've quite sorted out exactly what the expectation is on the part of both physicians and docs when it comes to this, and patients when it comes to this kind of syndrome.
So one of the other things that historically got in the way was that whole families get respiratory syndromes or upper respiratory pathogens rip through houses, right? But then only one person would come out with this syndrome. So, that can't be real. There's like a bunch of stuff like that. And the other thing is that the first interest in this really was around paralytic infections. So like the possible symptoms originally in these diagnoses were so extreme, right? And happening to such a small number of people for most infections, there's been epidemics that have led to quite a bit of paralysis, but yeah, so because of that, the list of like symptoms just kept shifting. And that I think also contributed to this. Just not believing them. But the bottom line is, if a patient had a mental health disturbance also, like, which you would if you were fatigued or had been sick, or within inches of your life, it was a more severe infection, it would just automatically be dismissed as being like psychological.
Yeah,
so
you pointed out an important thing, which is that there's no test for it, right? So that remains a problem. And physicians tend to we like tests. We like to, if they're negative, we say, hey, your tests were negative, time for you to go home. And especially when there's no treatment for it. And we'll get into prevention and treatment here in a little bit. Yeah. But this is, I think, some of the barriers for this being mainstream.
I mean, the horrible upside is that we now have, because of how inexpensive it is to say, look at, what everybody's immune cells are doing. We have basic research that shows that there's like really strange disturbances in like white blood cell production. And we have even more than that in just like straight up bone marrow. And like we have information now that actually shows, and it's not unified, but it shows, okay, these people recovered. They have these symptoms, the acute phase of this infection has ended. They're no longer carrying this virus. And here is all this weird stuff that's happening on the other side, right? Including like brain changes. There's a bunch of things that we've found. So like we know.
Yeah, so can you go through the list again, right? So you have changes in white blood cells.
So white blood cell phenotypes change a bit. We see it's so variable though. Like it's hard to say. They just like deviate beyond normal. So in some cases they're more pro-inflammatory. In some cases we see the production, and this happens in the acute phase of the infection too. And it may happen in lots of infections, but that B cells will start to produce autoantibodies. Like they'll produce antibodies against you, and specifically against like nuclear matter inside like cells. So we'll see those, and then they disappear, or then maybe they don't. There's signs of nerve damage. People lose hearing.
Taste. The whole taste bud thing, right? And smell. That's something that we learned about early on.
Yeah, absolutely. Right. Which,
so all these are under that umbrella. So here's a question from Nicole Hudson. If I think I'm experiencing these symptoms that could be indicative of one of these syndromes, who do I go for? What kind of doctor should I talk to? This is a great question.
Yeah, it's tricky. So here's all the advice I would give just as a member of the public. Anytime you think you have COVID, you should be in a clinic somewhere getting some kind of a test that's being recorded. So either you're getting a real-time PCR test or you're getting an antigen test in the clinic, so that it is marked down. That would be my suggestion.
For research purposes.
For research, well, not just research purposes. It was like you have you have a reference point. Someone can't dismiss the fact that you had it. Now you could take pictures or do whatever all else you want with your own test, because of course, like thinking you have it and showing up someplace is not the most responsible thing to do. But you want a record that it occurred, right? Because you need to be able to point back to that. And the next thing I would say is that hypothetically, your general practitioner should be able to refer you out to a variety of different people based on what your symptoms are. But if you want special treatment, meaning like if you want specialty treatment, there's only a handful of chronic fatigue clinics across the United States. It's something like 7. And there's one major medical center that's engaged in long COVID. There's lots of long COVID studies, but one major medical center that's like treating a massive cohort. And that's at Northwestern University.
Oh.
There's only a few others that are doing that on a slightly smaller scale. So my suggestion,
hopefully that will change, and hopefully there'll be more recognition
that's
of
the
this.
thing, right? It needs to change, especially if the approach to this, which appears to have been this administration's approach, which is like, it's so important to get back to work, guys, the economy, which has necessitated more exposures. Right.
Oh,
so
yeah.
this pushback to a normalcy that can't be achieved has led to a ludicrous number of exposures. So many exposures that like the United States life expectancy has dropped by 2 years.
It's really shocking. I saw some of those data this morning.
Yeah.
It's really distressing. I agree. Hey, there was a question early on. There we go. Yeah. From Katie. The question here is, on average, how long does post-viral COVID last? Or is it different for everyone? I have my own thoughts about this. What do you think?
It's really, really hard to peg it. So if you'd asked me a year ago, I would have said for the chronic fatigue syndrome as like the post-viral syndrome that looks most like chronic fatigue, at that time, it was thought a year or more. It could be 3 months. Average resolution at that point was like 8 or 9 months, but there were lots of people that showed evidence of going on for a year or more. If you're a child, as in like under the age of 18, but specifically kids under the age of 12, at that point didn't seem to go on for much longer than 5 months, but that's probably not true now. And if you think about, it doesn't appear to be the case. So, and if you think about how chronic fatigue syndrome works with progressive chronic fatigue and chronic fatigue that you would think about as being relapsing, remitting, it's around like forever.
Yeah, so that was my question for you, is like, are we ever really the same? Or like after we've been exposed to a, horrific virus like SARS-CoV-2, are our bodies ever the same?
Yeah. So I would say clinically, that's a different question than say immunologically. Immunologically, no. If you have a big immunological assault,
we're different.
Your bone marrow is different. It's just different afterwards. It's regulated very differently. Yeah. Yeah, that's the case, right? So you are different after the fact. And even if it was just mild and it didn't really lead to a whole lot of bone marrow changes, and just keep in mind that we only can see the changes that we can see.
Right.
So, right, which is the big difference.
The spotlight in the wrong direction, we're gonna
right, exactly. You can only know what you know, right? So, but even if you just had mild stuff, I mean, hypothetically, then you have some adaptive immune memory that develops that is a change too. And that means that incoming things that look like this will be treated differently and not necessarily positively. So,
right.
Yeah.
So we can get here into treatment here in a second. But I wanted to ask you while I had you, this autopsy data or these intestinal biopsy data that show these persistent infections that seem like the infection doesn't go away. We can find nucleocapsid protein in the intestinal biopsies and people that have supposedly recovered entirely from COVID months ago.
Right.
And autopsy data are showing detectable virus in a variety of tissues. So this really kind of, this is new stuff and kind of scary. And should all these folks be getting kind of persistent long treatments for their symptoms, or what can we do?
Right. Yeah. So a couple of things. It's important to know if what's isolated can replicate, because we know already that with at least this coronavirus, you can find parts and components like 60, 90 days out. So that's the first thing, right? The second thing is that I would say it would be also, is it the outcome of a second infection?
Right. That's going to be tough to know, isn't it? Especially
right. And then thirdly,
we're back to work and we're like engaging with the economy and no one's wearing masks anymore.
Engaging with the economy.
Whatever.
With naked faces, right? Like, let's just do it.
Here we are. Yep.
Right. And then the third thing I think is important is probably age. If we were going to talk about who's most likely to sustain like a subclinical infection for the longest amount of time, I would think it would be somebody who was already immunologically kind of hampered. So it'd be somebody who's either senescing or meaning immunologically, like, because once you get over the age of 55 or 60, things start to just shift and change in terms of production. And if you produce more of one type of cell, it changes all of the interactions among the milieu of cells. So so things go a little bit differently when you're a little bit older. But and then lastly, in some cases, and this is true very likely of long COVID as well. So to keep in mind that long COVID as a definition right now is probably a series of overlapping and even interacting conditions. It's not just one condition. It's a bucket into which a bunch of different conditions are being thrown. And it includes things like people who develop heart disease post-COVID-19 or people who develop MS post-COVID-19. And so if you're looking at someone who had like a progressive autoimmune disorder and didn't know in advance, you might also see persistent replication after the fact subclinically.
Right.
So yeah.
I want to jump in here because we're kind of getting close to the end of the show. And, we always kind of try to talk a little bit about the evolutionary side of things here since, our Dr. Zed is an EvMed specialist. And, why long COVID exists, like in evolutionary terms, like why is it a problem? Is there, is it because of how we evolved as organisms to like deal with
I think it's
problems?
how we evolved and also how the virus evolved, both. So obviously our bodies are an evolved system, and so we can't ignore that part. But SARS-CoV-2 is a particularly subversive, manipulative actor, and it wins and it gains fitness advantages by impairing our ability to survive and reproduce. And in particular, it dysregulates our immune systems, and it can have these persistent long-term effects on us. And it can also induce, there's some other viruses that cause antibodies against things like interferon. So we have our basic innate immunity toolbox to fight these viruses gets impaired by SARS-CoV-2 and other viruses. So that explains a lot of the symptomatology of long COVID. And like I said, I don't think that our bodies are ever the same after we've experienced something like this. And so for many of us, our bodies exhibit these long COVID symptoms. And what do you think, Jessica?
Yeah, so I agree with all of those things. I think it's a car crash of two evolutionary trajectories.
There you go. That's a great image. I love that.
Right. But what I was going to say is that there's some really important information that's connected to all of this, which is that like we don't have to have this condition. We don't have to have any of these conditions, right?
Oh.
We can stop we cannot stop it. We can like limit the movement of influenza and Coxsackie viruses and SARS-CoV-2 and those sorts of coronaviruses by doing all the things that we've been saying to do this whole time. And we can there's limited evidence right now that if you're vaccinated, you are maybe statistically significantly less likely to develop long COVID symptoms.
Yeah.
So
quick shout out to Eric Topol. He has a Substack and a recent post in which he kind of goes over this. And vaccination does, the preponderance of evidence suggests that vaccination does protect against long COVID. Doesn't completely eliminate it, but it does protect against it.
Yeah. I mean, it's again, though, it's like you said, the preponderance of, but it's still small. So Veteran Affairs has the EPIC study, and that's its specific mission. How can this be prevented? What are the factors that like contribute? Vaccination is like highlighted as like, this is the main thing that we want to examine.
Besides vaccines, also Paxlovid. If you have a risk factor for serious disease or age or anything else, and you meet the criteria for a Paxlovid prescription, that seems to also protect against long COVID development. And also metformin. We do have a little graphic, I think, maybe of metformin showing they are survival curves, but they're really showing whether one gets long COVID. And there was a randomized controlled trial of metformin, and that seemed to actually do the trick. There it is.
There it is.
There's a big separation between placebo and metformin. Metformin, of course, is a diabetes medicine. So thanks for showing that briefly.
I would also say that the number one thing is to not get it in the first place. Because people who are vaccinated, plenty of people who are vaccinated and have completed the entire series of vaccines develop long COVID. It's so bad. Like I just urgently want to like impress this upon you that 1 in 5 people who have had COVID have a long-term symptom going on after the fact.
So the prevalence is huge.
Right?
And as Mizella Kazi has mentioned in a previous little comment, it does seem to affect a lot of women, even healthy women, middle-aged, 20s, not even young women through middle age get this. But of course, men do too.
It affects kids. Like this is something that we've brushed aside children this whole time, right? Like this from the very beginning. Oh, not so bad in kids, not so bad. It absolutely affects children. There are children with long COVID too. It affects everybody, right? And so it's 1 in 5 to the point that something like, if we just want to put this in terms of the economy,
Mhm.
The U.S. government estimates that $50 billion a year are like in salaries is lost to long COVID and only long COVID specifically. So like if we're just going to be like the Leanna Wens of the world and think about the world purely from that standpoint, then yeah, it has a
All right.
huge impact
So
that way too.
Yeah.
Yeah,
Totally
never mind.
agree. So
Never
can we
mind all the
vaccinate
horrible
our way
things.
out of long COVID? Maybe, maybe not. Maybe boosters are the answer. This remains mostly unstudied. I think, Jessica, you were going to talk about some studies that people could join.
Yes. Okay. So there are a couple of studies that the U.S. government is throwing a lot of money behind in their national research action plan for long COVID. So there is Inspire, Recover, and Epic. Epic is being run through Veteran Affairs. The other two, and I apologize, I can't remember who the partners are, but they're readily findable. There's also You Plus Me, which is being run through one of these grassroots one of the largest long COVID grassroots organizations out there. So if you have symptoms, a strong recommendation that you look into these cohorts and volunteer.
So this is an evolving topic, and that's a great way to participate. But I think at this point we're probably going to have to wrap things up.
Can I say one last tiny
Of course
thing?
you can. You can have the final word.
I did a calculation on this last year. So last May, I sat down and I was like, how many people have been infected in the United States? And got an estimate of how many people. And then, okay, at 8 to 30%, which is the range right now for how many COVID-19 patients end up with long COVID, how many people in May of 2022 would presumably have or ever had long COVID? And it came out to 30 to 40 times the number of people. I think it's 30 to 40 times. I just want to make sure I get this number absolutely right. It was multiple tens-fold the number of people that actually, 10 to 30-fold the number of people who annually have heart attacks.
Whoa.
Yeah, that's really, really high.
Yeah.
Right.
All right. That is a truly apocalyptic note on which to end this conversation. But wow.
Yeah.
Something to think about. Like I said, this is an evolving topic. I think we'll probably get back to it because there's a lot of interest. And that wraps up another episode of the Dr. Zed Show. So thank you, Athena. Thank you, Dr. Brinkworth.
Thanks so much for having me.
Wonderful apocalyptic discussion. And we'll see you next time.
See you later.
And if the whole world says that we're crazy,